This week's topic is all about fetal and neonatal circulation. So as an overview, I'm going to start by just giving a brief overview on cardiac development, followed by a more in-depth description of fetal circulation, and then we'll talk about cardiac transition at birth. And since that cardiac development piece is pretty brief, I would recommend first going to your readings, and then I also put something in the bonus file this week that I think is a nice overview from YouTube. All right. So the heart begins to beat at 22 days. That's 22 days from conception. So we have vascular genesis beginning, so those vessels are starting to grow, and then blood flow is actually occurring during that 4th week. And then we have our partitioning of the atrioventricular canal beginning around the middle of the 4th week. And then that's actually done by the end of the 6th to the 8th week. So it's actually not very much time that basically our whole heart is formed. And then we have our foramen ovale beginning to develop within the heart not long after that. And we'll get back to that when we get to discussing circulation. So our heartbeat, if it's beginning at 22 days from conception, once you're in a clinical scenario, like you're actually in clinic, we're not really talking about days from conception anymore. We're talking about them with respect to somebody's last menstrual period. So we'll think about that as 22 days from conception, and then if you want to add to that 14 days to account for the last menstrual period timing to ovulation, and then if their cycles are consistently longer than 28 days, like say they're consistently 32 days, then we'd want to add another 4 days to that number. And the same would go if they're less than 28 consistently. You can subtract days too. So then that would be roughly how you would get a sense of when the heartbeat is actually starting, which is going to come to at least 5 weeks from the last menstrual period. And so if we're expecting the heart to start beating at 5 weeks from the last menstrual period, it might not be right around then that we would catch it on ultrasound, because usually when it starts, it might just beat a little bit, and then it would stop a little bit, and then it would start up again. So by 6, 7 weeks, with really good dating, we should definitely see it. But in terms of just if parents are asking you when does the heart start beating, heart starts beating by 5 weeks, at least 5 weeks. And then I just wanted to show a little clip here of a heart beating. So this one is 13 weeks, which I just did for fun so that we could see a little baby. You can see it's right here. See the flickering. So if you were doing an ultrasound, you could hover your mouse. Oh, this video goes on to be 40. You would hover your mouse over where you see the flicker, and then there's a button you can push where it will show you a waveform of the heart beating. I couldn't find any YouTubes that would show that, but it would show a waveform, and then you would freeze your screen and you would measure from the peak of one wave to the peak of 2 waves later, and then that would calculate your beats per minute for you. So just to kind of have a sense of that, you just kind of hover here, and then you would be. Oops, sometimes you have to follow it a little bit. So anyway, just wanted to throw that in for fun. Okay. So unique characteristics of fetal circulation. So fetal circulation, we have intracardiac and extracardiac shunts. And that's going to come into play in the next slide here. So other things besides the shunts to consider, we have a really high resistance pulmonary circuit. So without air constantly going to the lungs and filling up, we hardly need any blood there. We've got collapsed lungs, and then the smooth muscle of the pulmonary arteries, they're constricted. So it's a really high resistance circuit, which makes blood not want to naturally flow over to the lungs because they're not filled with air and the lungs are collapsed, right? On the other side of that, we have low resistance to our systemic circuit because you've got that force coming from the placenta with a wide open access to mom's circulation. We want that really wide open circuit, right, with really low resistance. So the placenta and the umbilical cord help to facilitate a low-resistance systemic circuit for the rest of the body. So fetal blood shunts, we've got 3 of them. One is found in the heart, that's the foraminal valley, and then 2 of them are found outside the heart, or extracardiac. So our one in the heart, you can see here, blood flows up from ultimately from the umbilical vein heading towards the heart, right? So blood flows up here through the inferior vena cava, and then when it gets to this point, because there's not very much blood returning from the lungs over here on this side, there's a lot more blood over here than over here. It would be kind of one way to think about it. And so blood can naturally just funnel through without going through the right ventricle. So actually, let's just take a step back and do a brief refresher on how we would usually see blood flowing. So it would come up here into our right atrium, down into our right ventricle, and then here through the pulmonary trunk, we're headed to our lungs on either side, and those would be our pulmonary arteries, and then they return as our pulmonary veins over here into our left atrium, down into our left ventricle, and then out our aorta. So the 2 shunts around the heart in fetal circulation are geared at bypassing the lungs. So there's 2 ways to do that. One is to skip even going to the lungs through the pulmonary trunk this way. So that would be shooting over through the foraminal valley. So that's like a hole in between, well, it's a flap really, but like a hole in between your right and your left atrium. And that actually, if you were to do an autopsy on a post-mortem adult, you would still be able to find that opening. It's just that after the birth, the pressure changes, and we really don't need it anymore. But oftentimes that never fully closes. So you all probably have a patent foraminal valley, but it doesn't matter because after the birth, there would be no purpose for it, and we'll talk about that later. Okay, so that would be one way to do it, but if we didn't go through the foraminal valley and we instead came up here through the pulmonary trunk, we have another shot at bypassing the lungs. Instead of heading towards the lungs, we can skip it and come up here through the ductus arteriosus. So that bypasses the lungs by going from the pulmonary trunk up to the aorta, excuse me. And then this last one here, the ductus venosus, that one will probably be seen best in the next photo. So I'm going to skip that one and come right back to it. So I'm just going to walk us through those steps one more time here. So we remember determining if something is an artery or vein. Arteries are heading away from the heart. Veins are heading towards the heart. And usually in an adult, we're thinking arteries have oxygenated blood, veins have deoxygenated blood, but we can't use that for fetal circulation. So we need to make sure that the definition we're using is, are we heading towards the heart or are we heading away from the heart? So that said, we've got 1 umbilical vein and 2 umbilical arteries. So our umbilical vein is heading towards the heart, so that's our oxygenated blood. So you can see this, so we get our oxygen from our placenta here, and then you can see this thicker red is our vein. So that's our 1 umbilical vein. And then this shunt here, if we want, we can bypass the liver and head towards the heart. So some of the blood will go to the liver, but then we're able to bypass that route and head straight for the inferior vena cava, which is nice because then the most oxygenated blood ends up more at the heart and in the brain. So that's just helpful that we have that option of not sending our freshest blood straight to our liver. So that's our ductus venosus, and then like we said, we've got the inferior vena cava up into the heart. We can follow the normal pathway, or we can do the skipping again, where we do the foraminal valley to shoot straight over to the left side of the heart, or if we've gone up in the pulmonary trunk, that can just go straight over to the aorta and even bypass the lungs as well as the left side of the heart. So we do what we need to do there, and then we see that our blood leaving the aorta. Some of it's going right to the brain, and then some of it's going to head down here for everything your normal circulation would do. And then right down here is where we're going to have on the way back is where we're going to have the option of coming back to the, well, not really an option, well, a good chunk of it anyway, is coming back to the placenta. And those would be our arteries because we're still going away from the heart. So we have 2 arteries and 1 vein, AVA. And if on ultrasound they're finding that there's only 2 vessels rather than having the 3, there's 2 main systems you want to think about. One would be taking a peek at the heart, and the other would be the kidneys, because both of those are related to having, like if there's a defect in kidneys or in the heart, oftentimes that ends up resulting in just having a 2-vessel cord. It's not terribly uncommon to just have a 2-vessel cord. I mean, I've only seen it maybe a short handful of times. It's not a cause for huge concern, but it is a reason to really make sure that they've looked at the heart well and the kidneys well, that there isn't something else going on. So it's more just a sign that we should do our due diligence and check out if there's anything else that's also off. Okay, so one last time, not trying to do this so much it's painful, but we have our placenta, and then normally we would take the longest way possible down this route, but we're just going to see how our shunts are helpful. So we have our umbilical vein, and then we can skip our liver and just go ductus venosus, and now we're heading up into the heart through the inferior vena cava. We're in the right atrium. If we want, we can skip the lungs and just go here, foramen ovale, which would be left atrium, left ventricle, and out through the aorta. Or it doesn't go through the foramen ovale, it goes down into the right ventricle, pulmonary trunk. Let's see if we can skip the lungs, shall we? And then we can just go over to the ductus arteriosus. So both those routes are skipping the lungs. So then we're in the aorta, and then it goes to systemic circulation, which eventually will end up in umbilical arteries. And then we're headed to the placenta again to get fresh blood from mama. And then just to emphasize here, so that fetal circulation, the pulmonary circuit is a really high resistance, right? So that's why we keep bypassing it. Versus our systemic circulation is a really low resistance because of the placenta and because of the umbilical cord. But then once we have our newborn, we're going to see that shift where the pulmonary circuit is a really low resistance and our systemic circuit is really high. So just to plant that seed that that's where we're headed. So let's just take a sec and think about fetal blood. So we're primarily using fetal hemoglobin to get oxygen from mom. So fetal hemoglobin has a greater affinity for oxygen, which it needs in order to get oxygen from the mother. So if mom and baby were carrying around the same amount of oxygen, it would be hard for baby to be able to strip that oxygen off of mom's hemoglobin and onto baby's hemoglobin. So there's also a lower partial pressure of oxygen in fetal tissues. So we think about babies are born blue because they're blue inside mom, and then they quickly pink up once they start breathing. But babies are in a permanently blue state in utero because they need to be lower in order to be able to strip that oxygen off of mom's hemoglobin. You could also see from the previous pictures that at any given time in baby's blood circulation, there's some areas with really high oxygen, other areas with low oxygen, and then other areas that are just really mixed, right? And so that also creates an environment in utero where baby overall is going to have less oxygen on board. So it's all of those components combined. So let's think about changes that happen then at birth. So in utero, our systemic vascular resistance is really low due to the placenta, but after the birth, between the cutting of the cord and the placenta shearing off from the wall, that's going to make a really high systemic vascular resistance within the body. So yes, it's cutting of the cord, though it's also the cord stopping pulsing. And I just mention that because every once in a while, if you're in a practice that lets you delay cord clamp to your heart's content, it's not as though you're going to interfere with baby being able to transition. So we have the cutting of the cord, placenta shearing off, or if you're cutting the cord, then it doesn't matter where the placenta's at. You've already cut off that connection there. And then systemic circulation is no longer a low resistance. That's basically what we're getting at. Okay, so then we have our functional closure of the foramen ovale. And I'll just kind of show you that here. So if we have a lot of blood coming in here, but then this is primarily what's coming from the lungs. If we're in utero, hardly anything ends up coming from the lungs, so there's a lot of blood here and very low blood here, so it naturally just pushes over. Whereas, once babies take their first breath and their lungs fill with oxygen, and you have that huge transition to then your lungs being a low resistance field, so much blood ends up in your lungs picking up that oxygen that as it comes back, there's extra pressure here, and that just shuts that valve closed. And like I said earlier, we probably all have patent foramen ovales, but because we have enough blood coming through this side, you don't have that mixing. So functional structure happens basically right away. And then structural closure of the ductus venosus happens about a week later. So now we'll talk about the ductus arteriosus. So this is the one between the pulmonary trunk and the aorta. Okay, so there's a functional closure of the ductus by about 96 hours. So about 10 to 12 hours after the birth, you've got smooth muscle contractions begin happening right around that shunt that makes it start to close, and then it's finally closed by about 96 hours. The reason it closes is really multifactorial. The process begins immediately, essentially, but then it really takes a while to fully close. So clamping of the cord, yes. Increased oxygen levels also contribute to this closure, and then production of catecholamines and decreased secretion of prostaglandins. So in pregnancy, the placenta is producing a lot of prostaglandins, and prostaglandins are what really help to keep the ductus arteriosus patent and open. So if there aren't prostaglandins, then it naturally is going to start to close. After the birth, you no longer have access to the placenta, so there's fewer prostaglandins on board, which is contributing to the closure. But then also those tissues aren't as sensitive to prostaglandins, making it want to close all the more. And I just want to bring up here that ibuprofen as well as indomethacin, they decrease prostaglandin synthesis, so that's why, especially in the third trimester, we're not wanting to give pregnant women ibuprofen because it can prematurely close the ductus arteriosus. So presence of prostaglandins keeps the ductus arteriosus open. Okay. And then anatomic closure happens by 2 to 3 months. Okay. So, I mean, that's essentially changes in the wall that are beyond just that functional closure that we see pretty close after the birth. So just wrapping back around, clamping of the cord, that also causes spasms. Once you clamp it, that would start to close off the shunts, all the shunts really, and then just all the pressure changes. So the pressure of having the low systemic resistance and the high pulmonary resistance, and then after the birth having high systemic resistance and low pulmonary resistance. So birth changes summary. I just basically said this, didn't I? So pulmonary, we have expansion of the lungs, which is going to lead to decreased pulmonary vascular resistance, which will lead to decreased pressure in the right side of the heart. And then systemic, no blood flow through the placenta. I'll let you read through that since I feel like I've told you guys 5 times now. And then finally, I just wanted to make a little note to have you keep in mind that with cardiac defects, depends on what one, but typically we'd want to maintain fetal circulation until you can repair the problem. And one way to do that would be to be giving prostaglandins to keep that shunt patent. And lastly, a word on cord clamping. So timing, basically we put it as late or delayed, or I'm sorry, early or delayed. So early would be within a minute of the birth, and that can interfere with the completion of normal physiologic transition, namely because if you clamp that early, babies will get about a quarter of the blood they would have otherwise, like a quarter to a third. So without as much blood volume, you don't have as much oxygen carrying capacity, so there's less oxygen delivery, and then that also is going to impact pulmonary blood flow to not have as much blood volume on board, which will limit lung expansion as well. So having baby's full blood volume helps with all of that. Exception, if you've got twins, as soon as that first baby comes out, you want to clamp and cut the cord so that all the blood doesn't shunt to one baby. And then hydrops fetalis would be another example of an early clamping intentionally. And of course, if you have a baby come out that's going to need quite a bit of resuscitation, it depends on what setup you have, but at least in most hospital situations, it's easier to just clamp and cut the cord and then take baby over to the warmer, where it's easier for multiple providers to surround the baby and give baby the care that he or she needs. If you're in more of a low intervention, I don't know if I would say low intervention. I'm just thinking out of hospital, if you don't have a lot of providers and your setup's easier this way, I often find the easiest way to do a resuscitation would be to have something like a cookie sheet available that you could put on the bed and put baby on so you have a hard surface. And ideally, if you can resuscitate the baby right next to the mom, then baby can be continuing to get oxygen from the placenta while you're helping get baby going. So there wouldn't be a need for that immediate clamping and cutting. So just things to think about, and knowing the environment that you're in and what's available to you helps you make those decisions as well. So late or delayed would be 2 to 3 minutes after the birth, but really, I mean, I've still got placentas that are, or umbilical cords rather, that are pulsing 8-10 minutes after a birth sometimes. So standard would be 2 to 3 minutes, but you could also just go till it stops pulsing. It's associated with increased, oops, I'm sorry you guys have to see all my little grammar stuff here. I can't seem to figure out how to change that. I think I spelled that right. Okay. Okay, associated with increased initial blood volume, so we have that extra 25-30%. And then sometimes there's some polycythemia, but that's transient and doesn't end up being an issue. And then less intraventricular hemorrhages have been associated with delayed cord clamping, as well as reduced anemia at 2 to 6 months of age. And actually, I've seen studies that show this well into early childhood. Reducing anemia. So something to think about, particularly if you're working with a patient population where their diets are low in iron, for example. Just something to be thinking about. And then finally, there have been some reports of increased jaundice for term infants only, but that's never been found with preterm infants. And it's not pathologic jaundice, it would just be physiologic jaundice, which I see often enough in mild forms that don't end up really needing treatment typically. Alright, that's it for this week. Go ahead and email me if you have any questions, or you can post them to the general forum. Have a good week, everyone.